a small amount of nitric oxide, which will be useful to induce bronchodilation through the increase of cyclic champing. At the same time, we also have a second family of enzyme, which is named inos, I for inducible. And this family of enzyme normally is not present in a normal cell. However, it will be induced in large amounts when inflammation is coming through pro-inflammatory cytokines, and those cytokines will make the appearance of inos in the environment, and this inos is very particular in the sense that it is capable to cause the synthesis not one, not two, but a great amount of nitric oxide, a large amount of nitric oxide, and this nitric oxide, which can be considered as a biomarker of inflammation, not only will take part of the inflammation, but will also actively be involved in what we call the oxidative stress, a hallmark of severe asthma that we are discussing today. Now, what is the role of type 2 cytokines in nitric oxide production? And we know that type 2 cytokines play an important role in type 2 inflammation. And we are going now to discuss with the help of my colleagues to better understand and to decipher the underlying mechanism leading to the link between type 2 inflammation and the synthesis of nitric oxide. Maybe Professor Kohn can help us to better understand this rather complicated slide.
Thank you very much. I will try to do that. So I know this is a very complex slide showing the different cells and cytokines that play a role in type 2 inflammation. And the pathway starts with the activation of the epithelium by allergens, viruses, etc. And the release of different epithelial cell cytokines, for example, TSLP, IL-25, IL-33, which you can see on the left-hand side. And they can all activate the innate and adaptive immune cells to secrete IL-5, IL-4, and IL-13 that you can see in the middle of this slide. And these type 2 cytokines, IL-5, 4, and 30, they can drive a cascade of downstream events, including the activation of airway epithelial cells, chemo attraction of effector cells, for example, mast cells, basophils, eosinophils, and of course remodeling of the epithelium. And I'm pretty sure that we are all very familiar with the effect of IL-5 on eosinophils, and we've learned a lot about eosinophils in the last few years, especially because of the availability of anti-IL-5 drugs. However, as you can see on that slide, there are other very important cytokines in the type 2 inflammation pathway. And when looking on the right-hand side of this slide, you can see that IL-4 and IL-13 have a particular role in FeNO production, and this will be part of the next few slides that will be presented from Professor Hepburn.
Thank you very much, Stephanie, because you really introduced the next slide, because we have seen that the patients with type 2 inflammation have a really complex inflammatory pathways that are including several cytokines and several types of cells. What I want to point your attention is that nitric oxide, as correctly said, is produced mainly in a patient with type 2 inflammation and underlying type 2 inflammation through a mechanism that is depending on IL-4 and particularly IL-13 mediated mechanism. But it is important to know that the nitric oxide is normally present in the airways because it is normally produced at epithelial level by the constitutive forms of nitric oxide synthesis and in a very small production. This is why when you assess nitric oxide in a patient without any disease, in a healthy patient, a healthy subject actually, you may find lower concentration, low concentration of nitric oxide. That is normal. And in a patient without type 2 inflammation, when there is a stimuli, a trigger, such as, for example, viral infection or exposure to pollutants and so on, the inducible form of nitric oxide synthase is anyway, let's say, enhanced to produce nitric oxide. So you will have a slight increase in the concentration of nitric oxide, but this is still in the normal level of FeNO. While in a patient with an underlying type 2 inflammation, so for example, a patient with asthma, but not only, a patient with nasal polyposis, for example, there is an important inflammation mediated by IL-4 and IL-13, which is inducing the overexpression of the inducible form of nitric oxide synthase, and therefore, when there is any single trigger, the increase of nitric oxide is still even higher. So that's the why in patients with type 2 inflammation, you have very high levels of nitric oxide FeNO, and you may have very, very high levels when there are triggers, specific triggers, can be allergic or non-allergic triggers that are activating the production of nitric oxide through the INOS, so the inducible form of nitric oxide. Here we have a list of the three most common biomarkers that are used in clinical practice in order to assess the type 2 inflammation. So, of course, used in office, because we know that the final, let's say, effect of this activation that has been seen before by an epithelial level is the recruitment of eosinophils, and this is mediated by means of IL-5, but through the activation of the IL-4 and IL-13 pathways. IgE also, of course, but IgE is much more associated with the allergic phenotypes, and type 2 inflammation is not always allergic, so the allergic phenotypes of asthma are type 2, but not all the type 2 phenotypes of asthma are allergic. And FeNO, which is much more useful in trying to really assess the type 2 inflammation, because as we said before, is directly produced by the activation mediated by IL-13 and IL-4. So it's an indicator of an IL-13 inflammation, and as we probably will see later on, is also an indicator of a possible increased corticosteroid responsiveness, and this is absolutely an important and clinically meaningful property of this biomarker, and so it becomes every day more useful in assessing patients with severe asthma in order to assess the level of inflammation in this patient, and as we'll see later on, also in order to better phenotype them, and probably looking also for more targeted therapies for this kind of patients. It's important, of course, to remind to you all that unfortunately, as far as now, no single biomarker can capture the full spectrum type 2 inflammation in asthma. So that is why it is advisable to use all the three biomarkers in combination, knowing the specificity of each single biomarker in giving you different information, different clinical information. I think this is an important message, because at the end of the day, FeNO is a biomarker, and we must know how to allocate this biomarker in the assessment of patients with asthma, with severe asthma in particular.
Thank you, Professor Hefner. We are now going to hear from Professor Chen.
Yes, I think that this is a very thorough and detailed explanation that really highlights how the heterogeneity of disease can now be tracked with different biomarkers. And it's not surprising to expect that with a disease that's as heterogeneous as asthma is, that you can't really track type 2 inflammation that is also somewhat complex, that has both innate and adaptive components with a single biomarker. So, tracking IL-5 with the eosinophil makes a lot of sense, and tracking IL-4 through the class switching of IgG to IgE is very helpful, and through specific IgE testing. And the importance of IL-13 in the upregulation of iNOS and production of FeNO in the inflammatory response is important as well. So I think that it really highlights the value to understand what's going on with these biomarkers in a given patient can really help you understand what's driving their disease and their disease activity. I think this would be a good time to just remind the audience to submit any questions that you might have through the chat function. And I think this would probably be a good time to take a pause and have some questions and answers from the audience regarding the heterogeneity of disease and the biomarkers and the slides that have been discussed so far.
So one of the questions is regarding FeNO. So regarding FeNO only or multiple flow rate FeNO?
If you want, I can comment on this. When we refer to FeNO in this presentation, we referred about FeNO 50, which is the FeNO measurement measured at a fixed flow rate of 50 millimeters per second, which is considered the standard reference for assessing FeNO. Of course, multiple flow rate FeNO measurement is another opportunity that may give some additional information on the location, on the distribution actually of every inflammation within the airways, but so far it's not so standardized and not so available, widely available as FeNO 50.
And just to follow on that, we do have a question from Australia with regard to that. This is used regularly in Australia, and they do want to know how to utilize it. Is that to adjust ICS treatment up or down? And what cutoff for FeNO would you recommend a biologic in case of a severe asthma patient? So there's quite a few questions on FeNO, and I'm trying to link those together.
Yes, I can handle the next question if you'd like. And I see here the question regarding if the FeNO is elevated where ICS use is high, how do you utilize it to adjust the ICS treatment up or down? And I think that's definitely one of the possibilities. I would say that we use it to help understand the level of inflammation that a patient has on inhaled steroids. And of course, you have to integrate the value of the FeNO in with the patient's clinical status. So if their disease is indeed uncontrolled based on disease activity or flaring, then we would adjust up their anti-inflammatory medication. Of course, in that situation, we maximize the inhaled steroid dose. And if that doesn't work after a period of time, we would consider adding a biologic therapy if they were on maximal inhaled therapies or some other kind of anti-inflammatory medication.
Thank you. So, is there any other questions that we can address?
There are quite a few. I guess one of those that we could address now is in a patient with symptomatic with allergic rhinitis, the measurement of FeNO showed 35. So below the cutoff of 50, but not negative either, but he had no decline in lung function or signs of respiratory symptoms. How would you interpret those findings?
Well, I think that Geoff is going to address this question later, but maybe you can just very briefly tell the audience what would you do in that case.
This is with the question regarding the FeNO of 35, or?
Yes.
Yes. So I believe that, in this particular scenario, which was presented by, was a patient with allergic rhinitis and an FeNO of 35 parts per billion. So below the cutoff of 50, no decline in pulmonary function or signs of respiratory symptoms. How would you interpret these findings? Well, first of all, the way the case is presented, we do know that patients with allergic rhinitis can have elevated FeNOs in the absence of asthma. So it could be partly a marker of the patient's allergy. But if this patient were indeed also had clear, and they may also have airway inflammation in the absence of respiratory symptoms. So this could simply be a marker, really a highlighting symbolic of the one airway hypothesis where you see some activation of the iNOS. However, I think the patient with, if it is an asthmatic and they have no symptoms, then I wouldn't necessarily adjust their medication unless I really saw some objective evidence through disease activity, flaring, or lung function decline that the patient had evidence of untreated disease or a poor outcome. I think the challenge for clinicians, and one of the reasons why we're having this discussion today, is the fact that this biomarker isn't perfect like others. And when you get into this range of 25 parts per billion to 50 parts per billion, there's a lot more complexity to how you interpret the value, and you really need to do it in the clinical context of the patient. So I know the cutoff of 50 is where there's clear-cut allergic inflammation. I think in the 25 to 50 range, it's always a little bit more complicated, but generally we like to use, most of the data suggests that in these severe asthmatics, where you're looking for unchecked type 2 inflammation, that a cutoff above 25 parts per billion is the proper cutoff, is a cutoff that's valuable to use.
Well, thank you, Geoff. Briefly, I would also comment that we should know for each individual patient what are the level of FeNO during, let's say, normal times while the patient is well controlled. But probably Stephanie or Enrico, if you want to add something from your personal experience on that very, very question. Maybe Stephanie?
So I completely agree with what Dr. Chubb said. So we see the whole picture of the patient, and it's not only elevated FeNO that makes us to treat the patient. So if it fits to the clinical signs of the patient, yes, we think about treatment, but if you just have a little elevated FeNO with no symptoms, so we would not treat that patient. But if it fits to an asthma diagnosis, we would think about that.
Yes, okay, we all agree. Enrico, do you have something to add?
Just final comment on this question. It is known that FeNO can be slightly elevated in patients with allergic rhinitis and even higher in patients with other comorbidities, which is nasopharyngitis. So, and this is probably due to the fact that is confirming that the United Airway disease hypothesis. I mean, the fact that the upper and lower airway are very similarly responding under the inflammatory point of view. But I agree with the other ones that only an elevated biomarker doesn't make a diagnosis of asthma, of course. So I mean, you need all the other.
Thank you
very much.
Yeah.
I think that now we should move on to the next. And its production and connection with type 2 inflammation. Now we are going to ask the important question, what is the utility of FeNO in the management of severe asthma with type 2 inflammation? And to address this question, I would like to invite my colleague Dr. Hefner to share with us his thoughts.
Thank you very much for the question, because there are really several aspects for which FeNO can be useful in asthma management. Starting from diagnosis, in fact, when a patient with consistent symptoms with asthma have high levels of nitric oxide, we can consider this patient as a patient with a type 2 inflammation, which is so the likelihood of asthma is increased. While on the other way around, the patients with low FeNO, even if they have symptoms of asthma, they may still have asthma, but the probability of getting a final diagnosis of asthma is lower. Another situation is in which FeNO at diagnosis level can be very high is when a patient has comorbidities, particularly respiratory comorbidities of asthma, such as chronic rhinosinusitis with nasal polyps, that is described to be one of those situations in which FeNO is very high, even when asthma is not present. So the production of nitric oxide lower level is very high, even when there is an upper airway disease, airway type 2 inflammatory disease, such as nasal polyposis. Please next. So the second important aspect is that when a patient is properly diagnosed and put on treatment with ICS, FeNO can be considered one of the biomarkers that can predict the steroid responsiveness, and so it can be useful also in optimizing the inhaled corticosteroids dose. Next one. And the other important aspect is that when we have a patient with asthma, which is put on inhaled corticosteroid treatment, even at high levels of treatment, so for example, a patient that can be defined as a difficult to treat asthma because it's treated with very high levels of treatment, but not reaching a good level of asthma control, where we have to think always about the possibility that this patient is not properly adherent to the treatment or not able to use properly the inhalers that have been prescribed. So you can use FeNO in order to test if the patient is adherent or not, because when the drug is properly administered, FeNO is supposed to be reduced during the treatment. So if you observe the patient taking the treatment in front of you in a proper way, you may assess FeNO in a sequence of assessment in different days and check if FeNO is really reducing or not. If it's not reducing, you are probably in front of a patient which is really corticosteroid resistant, while if there is a reduction, a significant reduction, probably the problem was the adherence or a non-correct inhaler technique. And finally, so last but not least, actually, external nitric oxide can be used in phenotyping properly patients with severe asthma in order to identify patients who are eligible for type 2 targeted biologic therapies. So now I pass the word to Dr. Chap that will discuss other aspects of FeNO.
So I think, as I mentioned, that exhaled nitric oxide is useful as a biomarker in management of disease, as was discussed, but it also has some predictive value. And here we can see how patients who have higher levels of exhaled nitric oxide have a faster lung function decline over a 3-year period done in this study of 128 patients. And I think it really mechanistically highlights that exhaled nitric oxide levels are linked to inflammation and the effects of the T2 cytokines we discussed, which may in fact lead to higher remodeling responses in the airway and increases the rate of lung function decline. In this trial, the level of 40 parts per billion was used as a cutoff for patients who had a faster rate versus a lower rate. But as we know, this cutoff can vary depending on studies that have been done, and there's no absolute agreed upon threshold. With some studies showing that levels above 25 parts per billion is associated with poor outcomes and can be predictive of more severe disease.
And this is also true when looking for exacerbation. So it's not only a predictor for declining lung function, but also a very strong predictor of asthma exacerbation. And this slide demonstrates that patients with higher FeNO levels have a greater risk of asthma exacerbations. If you have a cutoff of 37 or 25, for example, you can see that the patients with FeNO, for example, above 37 have twice as much exacerbations as patients with a lower FeNO. And in addition, if blood eosinophils is added as a biomarker, the prediction of exacerbations even improves. So adding an additional biomarker can predict asthma morbidity even better. And this is demonstrated on that slide. So the box at the bottom shows you that having another biomarker, the predictive value is even greater. So from my experience using FeNO for patients, especially very severe patients, help you to identify patients that are at risk for exacerbations. So higher FeNO levels are associated with a greater risk of asthma exacerbations. And on the next slide, we can see that if we look at different parameters, for example, patients with uncontrolled asthma exacerbations or patients with a low FEV1 airway obstruction, FEV1 below 80%, you can see that FeNO is one value that helps you to identify these patients that are at risk, and adding the next biomarker, for example, blood eosinophils, even improves the predictive value of these parameters. So in my opinion, even from a clinical point of view, I'm very happy to use both of these parameters to get a better feeling for our patients. And I think Dr. Chuck will go in more detail in the next slide to demonstrate how can we use FeNO in a clinical setting.
Right, so I think it's important to note that this really highlights one of the reasons why it's important to have more than one biomarker, because in any given patient, you may see a signal with one of the biomarkers and not with one of the others. And that all of these tests are not 100% sensitive or specific. So when you have both, for example, eosinophils and exhaled nitric oxide levels elevated, you can predict a very strong association with the outcomes that Dr. Korn showed. But you don't need both. And if you have one or the other, there's value as well. And maybe not quite as predictive, but still predictive of the outcome as the slide showed. So the nitric oxide-based clinical algorithms that help us guide management of asthma have really kind of shifted the threshold down to the 20 to 25 parts per billion range. And what we can see, I think, to summarize what the slides that have been shown, is that when patients have elevated levels of nitric oxide, above 20 parts per billion, then this is a marker in the clinical situation where a patient is not adequately controlled or has exacerbations or has low lung function, that you should spend special time and care to evaluate that patient and assess treatment adherence and their technique to ensure that they're using their inhalers properly, and consider additional treatments to maximize the anti-inflammatory effect. And if needed, consider a biologic therapy as add-on therapy, because in this clinical situation with a poorly controlled patient, it is likely that the T2 inflammation that is persistent is driving their disease activity and severity.
So
Well, thank you very much. I think that we have a lot of questions here. So maybe I will start to address some of those, and I will ask your help to address the other. One of the questions is the relationship between eosinophils and FeNO, and Geoff has already addressed that. So the question is there a relationship? I think that it has been shown that there is some sort of direct relationship between both blood eosinophils and, of course, between the eosinophils that you can recover from the expected sputum. But that relationship is not 100%. So that is why, and you have mentioned that, sometimes we do have both biomarkers, that is to say eosinophils and FeNO, both elevated, or both biomarkers being both low. And in that case, everything is clear. You don't have the likelihood to have type 2 inflammation, or you have a great likelihood. But in other case, one of the two biomarkers is high and the other one is low. You have already mentioned that, but I just would like to get your feedback from the three of you about your thoughts. Maybe Stephanie first, and then Lady first, and then Geoff and Enrico.
Thank you very much. I completely agree. In some patients, we see all the biomarkers elevated. However, we just do not have a small proportion of patients where FeNO is elevated and eosinophils are low, or the other side around. So this is why we are always happy to look at all of these biomarkers to get as much as information from these patients, and to categorize the patients to get a feeling how could we treat this patient. And it's not always high FeNO, high eosinophils. So it depends on the patient, and we see both high FeNO, low eos, or low FeNO and high eos, as well as high FeNO and high eos.
Good, very good. Enrico,
Yes,
and then Geoff.
Yeah, I completely agree with Dr. Korn. I think that none of these biomarkers, they all have variability, and they can be affected by different things. And so if you end up relying on a single biomarker, then you will miss opportunities to treat the patient, for uncontrolled T2 inflammation, and potentially add a biologic if you rely too much on a single biomarker to make a treatment decision. So I think it's important to look at all of three biomarkers that we're currently using in the clinic, specific IgE, eosinophils, and FeNO, to help make treatment decisions.
Thank you. And a very brief question, maybe Enrico, you want to add something before we move to the next question? Okay, so the next question is a very simple one. It's for pediatrician, but I guess that we can address that. Can FeNO replace spirometry in the infants? So can FeNO replace spirometry in the infants, in the children?
well, like if I can reply, well, FeNO cannot substitute lung function because actually it gives another information. But I understand that when we are assessing and we are trying to make a diagnosis of asthma in children, it may be difficult to perform spirometries, even if I mean the basic spirometry can be done actually in school age in patients over 6-year-old, while FeNO gives you another information, which is the inflammation behind. Of course, combining the two, you may have additional information on the pathophysiology that is sustaining the symptoms of the patient. So maybe putting together the two can help you in making the decision.
Thank you very much. We're going to go back to the video.
Great, asthma. Let's discuss the application of FeNO in the personalized management of patients with severe type 2 asthma. So now the question is, how does FeNO aid in predicting response to biological therapy? And to address this very important question, I will invite my colleague Dr. Chap to comment and to give us his thoughts on this very important question.
I think it would be valuable at this time to revisit the slide that shows the value of exhaled nitric oxide in the management of asthma, and really review some of the data that shows the relationship to exhaled NO and clinical response to biologic therapy in some of the pivotal trials. The Global Initiative for Asthma has now recognized FeNO as a valuable biomarker to help in predicting response to patients with going on biologic therapy against type 2 inflammation. And as you can see from the slide here on the left, patients, the different biologic drugs that are now available in the clinic are associated with different biomarker responses. And you can look at patients' FeNO levels in relation to anti-IgE therapy, eosinophils for patients with anti-IL-5 pathway therapies, and exhaled nitric oxide levels for identifying patients who are going to respond to anti-IL-4 receptor therapy, dupilumab, which blocks both the IL-4 and IL-13 pathways. And as you can see here, that patients with higher levels of exhaled nitric oxide have a stronger likelihood of response to the drug. So here you can see data from the QUEST trial, shows very nicely in subgroup analysis from that data set that patients with exhaled nitric oxide levels above 25 parts per billion had significant reductions in exacerbation rates over the clinical trial period, both the 200 milligram dose and 300 milligram doses of dupilumab. And here you can see, compared to placebo, the 200 milligram dose reduced exacerbations by 69% over the 52-week trial, and the 300 milligram dose had a 55% reduction in exacerbation rates compared to placebos. In addition, this tracked well with response to lung function as well. And here you can see a similar secondary subgroup analysis of patients in the QUEST trial. And the forest plot shows, again, in patients with nitric oxide levels above 25 parts per billion, which is now kind of recognized as a valuable threshold to identify patients with persistent type 2 inflammation, that dupilumab performed better than placebo at both doses in improving lung function in the QUEST trial.
We have a great discussion taking place with our panelists. So now let's continue with our next topic. Given the role of IL-4 and IL-13 in type 2 inflammation and the production of FeNO, what effects have we seen with dupilumab? And I will invite Dr. Korn to begin with your thoughts.
So first of all, I just want to start with the dupilumab history that we had in Europe. So first of all, we had the approval for atopic dermatitis. So patients with moderate to severe atopic dermatitis, 12 years and older, are candidates to be treated with dupilumab. Shortly after that, we got the approval for asthma as add-on maintenance treatment for severe asthma with type 2 inflammation. So patients who are not adequately controlled on high-dose ICS plus LAVA can be a candidate for dupilumab treatment if they have any sign of type 2 inflammation. And type 2 inflammation for dupilumab is characterized by raised blood eosinophils or raised FeNO. And last but not least, recently we got the approval for patients with chronic rhinosinusitis with nasal polyps, and we are just looking to get some experience for these patients, treating them with dupilumab. And I want to share a case report, a patient that we treated with dupilumab. This is one of our first patients to get an impression. How do these patients feel and do during dupilumab treatment? So this is a 47-year-old patient. It's a female patient. She had some allergies, especially against horse dander. She was an ex-smoker since 25 years of age, so she had less than 10 pack years. She had 3 severe asthma exacerbations in the previous 12 months, where she needed 50 milligrams of prednisolone for a minimum of 3 days. And she had a very, very long history of asthma. So her asthma was diagnosed when she was 5 years of age. And she told us that her asthma was getting worse and worse over the last years, so since she was 25 years of age. She claimed about dyspnea on exertion, nightly awakenings. She couldn't do any sports, and she was on a high dose of ICS and LAVA. In Germany, we normally treat the patients additionally with the LAMA if they are still uncontrolled despite ICS and LAVA. And of course, the patient had a rescue medication, which was salbutamol. These are the biomarkers that we had from the patient. So blood eosinophils were not very high with 140 cells per microliter. FeNO was elevated with 56 parts per billion. IgE was quite low despite the patient had some allergies. And the asthma control tests were 15 points, indicating that the patient had uncontrolled asthma. And when looking at her lung function, I know that this is not a very good lung function and not of very good quality. However, it was the best lung function that we could get from the patient. You can see that there was a very bad lung function with an FEV1 of 39% of predicted. These are some data of the QUEST trials. When looking at pharmacodynamic effects of dupilumab on FeNO, you can see that there is a marked effect of FeNO when treating the patient with dupilumab. On the left-hand side, you can see the results when treating them with dupilumab 200 milligrams. And on the right-hand side, when treating them with 300 milligrams, you can see there's really no effect when treating the patient with placebo, but a marked decrease in FeNO when treating them with dupilumab. So this is proof of concept, so the drug works. And we see a decrease of nearly 50% in FeNO. And of course, we were quite excited if this would happen to our patients as well. So now switch back to the patient that I just had introduced. So these are some of the biomarkers. Blue line at the top, these are eosinophils, and as you can see, she started with 140, and there was a slightly decrease of eosinophils over time. So normally after 4 months, We evaluate if the patient is a responder, so we see the patients again, we get all the biomarkers and lung function testing results and so on. So really no change after 4 months, slightly decrease after 1 year. And this is IgE at the bottom. You can see that there is a decrease in IgE over time. And this is FeNO, so the patient started with a fever level of 56 parts per billion. Then FeNO was decreased to 34 and then to 70. This is similar that we have seen in the QUEST trial. And when looking at another parameter, asthma control, which is very important for us as a clinician, you can see that the patient started with 15 points of uncontrolled asthma, and the patient improved over time to nearly controlled asthma. When looking at her lung function, this was lung function prior to dupilumab. We've already seen that. This was her lung function 4 months after dupilumab treatment, so a significant improvement. And after 1 year, this improvement was maintained. So the patient had a very quick improvement, told us that she was not waking up during the night. She needed to rescue medication nearly never again. She had no exacerbations. Of course, she was active and she could do anything nearly like a healthy person. So she could do houseworking and so on. So in our opinion, this is a typical patient that we could treat with dupilumab, and we see effects in biomarkers. So we are very happy to see these effects, and they are combined with a clinical improvement in this specific patient.
Well, I think that it nicely illustrates what we have mentioned before, especially the previous talks by Geoffrey Chubb and Professor Heffler. You have here a patient who obviously is doing better with dupilumab, with less inflammation, especially shown by a reduction in FeNO, better outcome and better lung function, as we can very clearly see here. It's very remarkable, and also less exacerbation. So by controlling inflammation, you actually is doing a lot of good things to those patients. I don't know, what do you think, Jeff?
Yeah, I think that this is really nicely highlighted in this case, that the effect of both using the exhaled nitric oxide level to select patients, and in this case that was the predominantly elevated biomarker, and how it is useful in predicting a clinical response, both in lung function as well as disease activity.
Yes, and there again, I think that we're concentrating our attention on FeNO, but actually it is a very sensitive biomarker for inflammation. So if we can control that inflammation, and if we can see how we can control that with the level of FeNO, actually we can predict what will happen to the patients. So if you agree, may I just remind the audience now to submit any question you might have to us through the chat function, and we will be very happy to address them, in the Q&A part of the discussion. Thank you very much. I think that now we are going to very briefly address some of the questions, and then we will go to the closing remarks. So I just have one question that has not been really addressed during the talk, is what about the role of FeNO in helping to assess the adherence to treatment in asthma? We know that there are data on that, so I'm wondering as to whether one of you can just give some comments about this. Enrico, maybe?
Yeah. Well, FeNO can be used to assess the adherence to treatment, also because of the fact that generally FeNO rapidly decreases just after the initiation of inhaled corticosteroid treatment. So if a patient is not adherent or not fully adherent, you may expect a higher level of FeNO despite the treatment, despite high level of treatment. So what has been suggested, for example, by the Liamini group was to test FeNO using the so-called FeNO suppression test. So observe the patient taking the inhalers for several days and monitoring FeNO during those days. And what you may expect is that FeNO decreases. If it does not decrease, it means that probably that patient is really corticosteroid resistant somehow, or anyway not so responsive to the corticosteroid. Otherwise, you are in front of a patient in which non-adherence should be suspected.
Well, thank you very much. I think that there's still a lot of questions to be addressed, and so therefore I would invite all the people attending this session to go to the breakout session. Some of us will stay there for, let's say, half an hour more to address all those questions with you. So it's now about time for us to thank you to be there, but the session hasn't stopped from here, and we will move on. Thank you very much, and see you right now after. Now we are moving to the last part of this symposium. Namely, we are going to discuss FeNO is a biomarker of type 2 inflammation with broad and practical utility in the management of patients with severe asthma. And I will invite each of my colleagues to make a summary remark about the rather broad and practical utility of FeNO in severe asthma management.
Well, in my opinion, the data we showed during this section really confirms that FeNO is really useful in a pleiotropic way, let's say. So because it's useful from the diagnosis point of view, it can help to put the diagnosis of asthma. It's useful for assessing the corticosteroid responsiveness of these patients, and therefore also the other side of the coin is to assess the patient who are adherent, or better, those who are non-adherent or not properly adherent to the treatment. And finally, that is absolutely relevant, and which is also probably the novelty of these last few months, is that FeNO can be really useful for phenotype in patients with severe asthma, and therefore looking for the most targeted and precise treatment for each single patient. And this is, in my opinion, what we really learned in this session altogether.
I like FeNO very much. I think it is a very fascinating biomarker, and I like to use it to identify patients, a specific subgroup of patients with type 2 inflammation, to select patients that may be eligible for a specific biomarker treatment, in such case with dupilumab, to follow up these patients to get a feeling how do the patients do, what happens with inflammation in the patients, to evaluate the treatment effects, and to see what happens when treating these patients and what's going on in their lungs. And I think asthma is a very complex disease, and I like to use it as another building blocks to just add to all the other biomarkers to get a complete picture of our asthma patients.
I think that FeNO is now recognized as a critical biomarker in the management of patients with severe asthma. And this is based on over 20 years of experience with using this biomarker that has been challenged at times because of for practical reasons, but has really one of the only ways that we can measure inflammation in the airway non-invasively. It is a cost-affordable test. It is point of care so that you can acquire it at the time of a visit and help so that it can help you make management decisions in patients at the time of the visit. And it has tracked very nicely, as has been shown with the IL-4/13 pathway activation and T2 inflammation, and it predicts outcomes in asthma and potentially remodeling in patients, as well as a response to biologic therapies. I think it's important that we continue to study FeNO and really confirm its rightful place in the management of asthma with prospective trials using it as a selection biomarker for the currently available biologics.
Well, I of course fully agree with everything that has been said, so I'm not going to repeat, but I would simply conclude by saying that nitric oxide is a gas, and this is a very particular gas because the amount of nitric oxide is increased during inflammation, and that is why FeNO is a rather sensitive biomarker for bronchial inflammation, and for all the reasons that have been developed so far, it is quite sensitive for type 2 inflammation. But because it is a gas, it is very simple, very easy to sample from the exhaled air, and that is why FeNO is probably the champ of a non-invasive way of monitor and detect inflammation in asthma patients, and especially in those with severe asthma in need for treatment with type 2, with anti-type 2 inflammation, as we have seen during the symposium of today. Thank you to our experts. This has been a wonderful discussion.